I'd like to thank you all for joining us today for another wonderful webinar presented by the AANS CNS Joint Tumor Section. We're really excited about this particular webinar. It's quite timely in terms of molecular diagnosis and the practice of neurosurgical oncology. I'd like to thank the AANS for really helping us get these webinars together. They're far-reaching, they're impactful, and quite meaningful, not only to the tumor section, but to other interested parties all around the world. So I want to thank everybody, and I'd like to thank Dr. Oranger for his emphasis on this webinar. Dr. Zadick, can you introduce our speakers?
Absolutely. Thank you, Dr. Hadji-Panayis. Good morning, everyone. We're excited about this fantastic speaker list focusing on molecular diagnosis and the practice of neurosurgical oncology. And our speakers this morning, I'm just going to run through them. The first will be Dr. Shawn Hervey-Jumper from UCSF, who will discuss differences in longitudinal outcomes among diffuse low-grade glioma subtypes, followed by Dr. Nduka Amankulor from Penn, who will discuss longitudinal outcomes in glioblastoma molecular subtypes. Next, Dr. Daniel Oranger from NYU will speak about unlocking glioma genetics in the OR, followed by Dr. Alex Miller, who is a neuro-oncologist from NYU. Welcome, Dr. Miller. And she will speak about molecularly targeted therapeutics in glioma. We will have a short break at the turn of the hour to be followed by Dr. Linda B. from the Brigham, who will discuss differences in outcomes among meningioma subtypes. And then we will close it out with Dr. Donato Passione from NYU, who will discuss the impact of BRAF V600E in surgical planning on craniopharyngiomas. We'll leave a little time at the end for discussion and Q&A, but we will now invite Dr. Shawn Hervey-Jumper from UCSF to begin his lecture.
Good morning, folks. Let me just share a screen. All right, does everything look okay? All right, fantastic. I'm honored to be here. Thank you so much, meeting organizers. This is going to be a great event, as Kostas said. So I've been charged here to kick us off by talking about differences in longitudinal outcome among low-grade glioma patients based on molecular subtype. And I have no conflicts or anything to disclose. It's important to think through not just differences in outcomes, but how our oncologic treatments actually influence these outcomes and what we as surgeons can do to impact how our patients live. I just want to put this slide up since I'm first on the docket this morning, and particularly for any learners in the room. What we're talking about really are molecularly subclass tumors based on the WHO 2021 diagnostic criteria. Again, of course, many of us have seen this, but if we're talking about adult type hemispheric gliomas, we're really talking about glioblastoma, IDH mutant WHO grade 4 astrocytomas. And what I'll focus on for the next 10 minutes will be IDH mutant grade 2 astrocytomas and oligodendrogliomas. The overall title did include low-grade gliomas, but again, in the short interest of time, I thought it was probably best to not cover DNET gangliogliomas and pilocytic astrocytomas, just so we can kind of keep the discussion a little more focused today. This is a group of just 5 patients that all of us see in clinic. These are the last couple I saw in clinic over the last couple of days and of the last couple of weeks. And it's really important to think through, right, as surgeons and neuro-oncologists, how are we defining what our goals of care are for these patients and our treatment recommendations, right? We know that all consensus guidelines begin with maximum safe resection, but how much resection and by what means, and what are the risks we put people through and why? What's the benefit associated with it? So let's kind of talk through some of these scenarios and the evidence behind how we guide our clinical decision-making for patients that come in with IDH mutant low-grade gliomas, particularly oligodendrogliomas and astrocytomas. I really like to start with the Tim Smith study. This is one of the Boston groups put together this really great study in Journal of Neurosurgery. It was published in 2021. They were early to the list in talking about IDH mutant gliomas after WHO 2021 diagnostic criteria. They really focused on patients, again, based on IDH mutant status with oligodendrogliomas and astrocytomas. You can ignore the wild type astrocytomas. I should erase that. That's a an old historical artifact that probably isn't relevant here. But you can see here that overall survival for both patients with oligodendroglioma and astrocytoma seemed to be associated with extended resection. And if we look at malignant transformation through other reports around this time, it was focused on the proliferation index or performance status, radiation, but also extended resection for these patients. So that was quite intriguing, right? Particularly given that in the literature, there were a couple of other reports that suggested maybe the benefit of maximum extended resection was only available or most pronounced for patients with astrocytomas and not oligodendrogliomas. So this became a really important area to study and think about. But the Tim Smith study, amongst others around that time, really got us started. There are a number of us have put together a report now published almost 2 years ago now, focused on a multi-center, multinational retrospective data set using a similar approach. Again, this is a validation or a discovery data set of all patients with IDH mutant grade 2 oligos and astrocytomas. A discovery data set at University of California, San Francisco, validated against Brigham and Women's Hospital and St. Olave's Hospital, a couple of other centers in different parts of the world to make sure these results matched up. The results here, what you're looking at is a recursive partitioning analysis, which is an approach to identify the overall drivers of overall survival risk of roughly 54 variables. And we can see here that in our recursive partitioning study, the variables or features that were most significant and identified 3 risk groups was based on the patient's preoperative tumor volume, postoperative tumor volume, whether it's an oligodendroglioma or an astrocytoma, and this interesting artifact of whether the patient received chemotherapy or not, which kind of have to not focus on too much because of some predictions in terms of who got chemotherapy over that 20-year period based on predictions of risk. So this was quite interesting in that the risk group 3 relative to risk group 1 included, again, risk group 1 worse was patients with large astrocytomas. There were no patients with oligodendrogliomas in risk group 1, and less extensive resection, particularly for patients with astrocytoma, all populated into this worst risk group, which had a median survival of roughly 9 years. Switching to the risk group 3, the best group, these are individuals with oligodendrogliomas with greater extended resection or less extended resection, as well as patients with smaller astrocytomas or medium to large size astrocytomas that had a complete removal. So this idea that extended resection does seem to shift survival to the right for these patients was quite intriguing, and it made our group look a little deeper. And this idea from the glioblastoma literature has been bleeding over into the low-grade space in terms of what is the survival advantage associated with removal of tumor outside or brain outside of the flare volume in patients with IDH mutant low-grade gliomas. So we took this to task a little bit, this idea, and categorized patients as either having a GTR plus, as we called it, that's extended resection outside of the imaging defined margins, or gross total resection, meaning complete removal of the flare, or anything less than that, that's 99% extended resection. I call this view the surgeon's view because these are, again, patients regardless of or combined oligoastrocytoma patients together. You can see here again that gross total resection plus or resection outside of the imaging defined margins has associated with a overall survival benefit relative to gross total resection, relative to a 99% or less extended resection. There's some important parts to this that I discuss with all patients that that come to see me. And notice this here, again, your GTR minus and your gross total resection survival curves don't split for about a decade. So the risk we put patients through for a gross total resection is for typically patients in their 30s, really should be thought of for what this is going to buy them in roughly a decade from now, right? So we want to do a great complete resection as much as possible. But as we discuss these sort of risks with the patient, we want to understand what's driving them, what the neurologic impact might be for them, because again, survival or just outcomes for the first decade should look pretty similar, whether they have a complete or an incomplete resection. But if we take apart the surgeon's view and really focus on just patients with WHO grade 2 IDH mutant astrocytomas, we can see a similar approach where gross total resection plus is a benefit relative to gross total resection, relative to gross total resection minus. If we look at patients with oligodendrogliomas, we also see that these folks need a complete resection, if at all possible, but a GTR and a GTR plus co-localized. These folks live together. So at a 20-year survival for roughly 400 patients, of which roughly 200 have oligodendrogliomas, it's a 20-year follow-up, gross total and gross total resection plus seem to be the same. So not overwhelmingly impressive data to suggest resection outside of the imaging defined tumor margins for patients with IDH mutant grade 2 oligodendrogliomas. I like to put this slide in here just to remind us that while we understand and really agree on overall survival progression, particularly for patients with low-grade disease, is a little harder to follow. Each center has even using RANO criteria, has a slightly different metric for progression-free survival. So in these sort of analysis, we lump all patients together instead of a discovery and validation data set. But here we can see the major drivers of progression-free survival. Again, oligodendroglioma versus astrocytoma. Again, postoperative volume with these cutoffs is what comes through. And you can see the risk groups associated. Last piece, malignant transformation-free survival, really important characteristic here. Again, as you can imagine, oligo and astrocytoma, postoperative volume, age, again, all associated with malignant transformation-free survival. I want to kind of finish this off with this analysis here. Again, it's really hard to run a trial that's benchmarking patients or annotating patients based on extended resection, right? We have clinical equipoise, there's ethics associated with that. So if we could propensity match a large enough data set, which all matched known prognostic variables are matched together, we can look at overall survival combined together based on extended resection going from 60% to 100%, and not survival, but hazard ratios, and understand based for overall survival, which is the blue line, which cutoff point does our extended resection suggest a change in hazard ratio or statistically significant hazard ratio. And in this data set, it was roughly 75%. That's where the survival benefit, that's where you have a statistically significant association, and you can see these hazard ratios drift to the left with an extended resection of 75% to 100%. So I really think of this as a dose of drug or a dose of treatment. And we know that 75% on extended resection does offer a drop in hazard ratio for patients. I think all of this data has to be reconsidered in light of clinical trials for targeted molecular therapies, particularly the vorasidenib INDIGO trial that was recently published right after this report came out, which really points to some really particularly impressive or exciting treatment options for patients with residual disease that are recurring. And so with that, and I know we have a talk focused on that, I'd like to say, like, as we think about each of these patients with IDH mutant grade 2 oligodendrogliomas and astrocytomas, what we choose to put patients through or think about our extended resection thresholds, of course, varies quite a bit based on whether we have an oligodendroglioma, astrocytoma, age of patients, and maybe everything from relieving a patient with mass effect who's 18 years old with trying to maximize extended resection, preserving cortical spinal tracts and things like that, to folks such as the far right, a 19-year-old who's just starting college, who doesn't want to have to go through recovery of an SMA syndrome and maybe cognitive changes associated with that. Because we may have some targeted molecular agents that we can put patients on, at least to buy them time, knowing it may not cure their disease, or we don't know that to date, but at least can include that in the treatment plan for these patients. So I want to stop there and say take-home points really are that surgical goals are a little more nuanced in light of glioma subclassification. Again, we want to give patients an excellent surgery. Gross total resection plus is probably a benefit for many patients, particularly IDH mutant grade 2 astrocytoma patients, but may not be for all patients, at least at 20-year survival. And much more needs to be talked about or thought about as we try to deliver the best therapy for our patients. So with that, I think I'm about a minute over. Guys, thank you so much for the opportunity to be involved in this webinar. And I'm not sure if we take questions now or or go through the talks and maybe take some discussion at the end. So
I think
thank
we'll do some discussion at the end. That was fantastic. Thank you, Dr. Hervey-Jumper. We have a little time. I may just ask you one quick question that came to
Sure.
mind, if that's okay.
Sure.
Where are you, or where are we with rapid intraoperative diagnostics? In other words, testing right away to know during an operation if something is, let's say, IDH1 mutant or wild type, and are you using anything like that currently?
I would not dare steal from Professor Origer's talk, which I guarantee a few slides to the end.
Okay,
Yeah,
very good.
at our center, it's probably not fair to say this because it's investigational and not standard of care yet, but we use optical imaging technologies to get us some diagnostic yield as to whether we're thinking about an oligodendroglioma or an astrocytoma, both for classifying tumor subtype as well as quantifying tumor burden at the margins. But again, that's investigational at this point. But I think Dan will go into that in great detail.
Excellent. Okay, well, with that in mind, I think we are going to go directly to Dr. Oringer now for his lecture. Thank you for that fantastic lecture. Dan, let's have you load your slides up, and thank you so much. Looks good.
I'm just getting loaded here. Okay, slides look okay, Cap?
Looks good. Yeah, you're all set.
Thank you, Shawn. Thank you to the tumor section, I should say first. Thanks to Dr. Hadjipanayis and Dr. Zada for the opportunity to present within this webinar series and to help put this webinar together. I'm going to be talking about how we access some of the genetic markers that Dr. Hervey-Jumper covered and that seem to make an increasingly large impact on our surgical decision-making. Just to start off with some disclosures, I have some ownership interest in some of the companies that I'll present technology from in this presentation, just to share that. So to back up a little bit, increasingly we know that brain tumors are a molecular disease. And when a number of us who are presenting started in neurosurgery, we never even thought about the genetics that were driving this disease in a diagnostic way. And now we fast forward 20 years, and it'd be hard to separate brain tumors from genetic diagnosis. However, in the operating room, what we see is what is shown on the screen. And we see what's happening macroscopically, even with our microscopes. We're seeing what's happening pseudo-macroscopically, and the disease is occurring on a genetic level. So what my research efforts have been dedicated to, and increasingly a translational effort, is closing that gap between what we see macroscopically in the OR as surgeons and what's happening at the level of genetic alterations, and how we can leverage an increasing ability to access that genetic information and put it to work for our patients. So there are a number of alternatives to answer Dr. Zada's question, timely question, about how we can access genetics during surgery. One of these approaches is ultra-rapid nanopore sequencing, and that's work that was done outside of our lab by Vermeulen et al. That was published in Nature in 2023. And that's a very powerful technology. I'm not going to focus on it, but just to call the attention to it that I think it deserves, nanopore sequencing creates like a sparse methylation profile of the tumor tissue during surgery. And the turnaround time from tissue to methylation profiling in this workflow is a little bit more than an hour. And that's quite a remarkable accomplishment. I would say that, that's probably a level of information that at this point, we don't have a way of assigning surgical utility to. But what does really matter, based on Dr. Hervey-Jumper's work, is understanding whether a tumor has an IDH mutation, beyond that, whether it's astro or oligo. And we've been working on two technologies that allow us to do that. The first of which is called stimulated Raman histology. And this is a label-free imaging technology that we use sort of as a substrate to generate microscopic images of tissue in the operating room. And the way that this works is that we have fresh tissue specimens that we image with nonlinear optics to generate a virtual histologic image. And for the purpose of this talk, this is a technology that I was very lucky to get exposed to when I was a resident, and ultimately focus a lot of my research attention on. But for the purpose of this talk, what we're doing with those images that we generate in the operating room of low-grade gliomas is applying artificial intelligence algorithms to those images to decode the genetics. And my former student, former resident, former fellow, current collaborator, Todd Holland, pioneered a way to apply some advances in artificial intelligence, specifically ways of analyzing images and putting them in a semantic space that takes into account the genetics of these tumors to be able to accurately and very quickly differentiate oligodendroglioma from astrocytoma. And like, what does this mean in the operating room? Well, Dr. Hervey-Jumper's paper was really a landmark in my group because it showed us the curves that he just showed us, and are so meaningful because it showed us that there really is a difference in how patients do with varying degrees of extent of resection. And whereas in astrocytoma, there's a big difference between gross total resection and gross total resection plus. For oligos, there's no statistical difference between any of the surgical outcomes in his study. And so that means that for patients with astro, the completeness of resection is critically important, possibly to the point where we're really pushing the limits of what maximal safe resection means, because it's really a defining factor in survival. For oligodendroglioma, however, those curves are literally on top of each other. And so any neurologic deficit that we might cause really comes at a massive cost without much potential upside. So we need to probably be a bit more conservative, but knowing the difference between astro and oligo is really not something that can be reliably executed using microscopy. Even the best neuropathologists may disagree between those two. And so having a test that, like we have in the operating room now with this algorithm called deep glioma, allows us to differentiate between those two and gives us access to that genetic information that should dictate surgical strategy. So that technology, stimulated Raman histology, is powerful, especially when we have dense tumor, like we can see here. These are some axons, and the rest of these are tumor cells. And so in an image like this, we have a lot of data that we can feed into this algorithm to help differentiate oligo from astro. But at the tumor margins, when we're thinking about, we're sort of shifting our focus now towards using that molecular information to make surgical decisions and achieve the surgical outcomes that we want, it's really hard for our algorithms to differentiate at the lower limits of detection of the microscopy technology. So we turned to a wet lab method called digital droplet PCR. And that method, as it exists in the lab, is widely used, but it takes several hours to turn around. So that couldn't be executed in the context of the operating room in its current form. My collaborator, Gilad Evroni, and his students developed essentially a way to accelerate elements of that process dramatically in a couple of regards. First of all, they figured out a way to dramatically condense the time it takes to extract DNA in a way that preserves droplets, which we can see here that encapsulate individual PCR reactions. And then thermal cycling, which typically takes so much time, hours, during a standard droplet digital PCR workflow, we can accelerate by changing the concentration of enzymes that we're using, the specific enzymes that are most effective in the situation, and condense this process down to 3 minutes. And we developed all of these technologies essentially in a molecular biology lab, put them on a cart and brought them into the operating room, and found that our ultra rapid assay that we turn around in a matter of 15 minutes or less has the same accuracy as the droplet digital PCR that takes hours in the lab. So we developed a workflow based on this technology. And essentially what we do with this workflow is to take fresh tissue specimens, extract DNA, and then we can use that ddPCR to estimate the variant allele fraction, the percentage of tumor cells. We can use stimulated Raman histology to count the cells. And between the percentage of tumor cells that we get from droplet digital PCR and the counting of cells that we can do with stimulated Raman histology, we can determine exactly how many tumor cells are in a specimen that we've taken out in a very fast way to allow us to iterate. We describe this in detail in our publication that will come out in the next few weeks in Med. And interestingly, this works also for other genetic loci, and we're developing a whole panel that should cover the vast majority of the spectrum of human tumors. Just to give you a flavor for how this works, it's probably best to think about this as mapping. The kind of mapping that we all think about as brain tumor surgeons is functional mapping. But with this technology, we also have the ability to now map for tumor cell content. So in the course of a normal operation, we'll perform a gross total resection, take out everything that we think we can, and then we can take some tissue specimens at the margins and analyze them for how much tumor content is there. And amazingly, and in a humbling way, we know that sometimes our margins are very clean, like we see in this anterior margin. Other times, the margins have an allele fraction of tumor that's very high, in this case, 38%. And then over time, we can track where the recurrence seems to be occurring. And the goal in the future is to, for those cases where tumor can be safely resected in total, especially for astrocytoma, our goal is to get every margin down to this level or even lower, and make sure that patients don't leave the operating room until the allele fraction is essentially at baseline. So those are two methods that we are developing right now. And I think they point to two separate needs, but this is all to say, just to summarize, that we have an increasing number of technologies that allow us to both determine genetic diagnosis in the operating room and determine the true mutational burden, the true residual amount of tumor left in a surgical cavity at the genetic level. I just want to thank collaborators. All of this has been a very multidisciplinary effort. Thank you.
Awesome. Thank you, Dan. Really amazing stuff. And we know you're doing a lot of pioneering work. So I heard down to 15 minutes and even down to possibly 3 minutes for certain intraoperative detection methods. Is that
That's right?
That's where you're headed? It's going to be really exciting to help us guide along with optical fluorescence technology too. Those are going to be really powerful in combination. That's really amazing work. Congratulations. Okay, I think we will move forward. Our next speaker is Dr. Alex Miller from NYU. Dr. Miller is a neuro-oncologist who will be speaking about molecularly targeted therapeutics in glioma. Dr. Miller, thanks so much for joining us today.
Thanks so much for having me, and hopefully, I'm not sure what's going on here. I'm having trouble sharing. Maybe, Dan, I'm going to send you these slides to share.
Sure, no problem.
Let me see if I can, I don't know why that is. Should be able to.
Okay, sorry about that. I
All
think it may be something with my Zoom. Dan, I just sent you a link.
I'll keep an eye out for it.
Thanks.
Do you want us to come back to you? We can see if one of our other speakers may be.
Sure, whatever you prefer.
Okay, is it Dr. B, are you by any chance ready to go?
Sure, absolutely.
I know we're off schedule a little bit. I did see you here. If you're ready, that would be fantastic. So let me just welcome Dr. Linda B from the Brigham. She is a leader in meningioma surgery and research, and will be speaking to us about differences in longitudinal outcomes amongst meningioma molecular subtypes. Thanks so much, Linda, for joining.
Of course, what a pleasure to join this wonderful group of friends and colleagues whose work I respect. Thank you, Dan, for the kind invitation to be part of this. Is my screen sharing okay?
Yes, it looks perfect.
Okay, wonderful. So it's a delight for me to speak about molecular subtypes of meningiomas. And the reason that I think meningiomas have, and especially in the recent decade, upgraded in concept, similar to the gliomas and pediatric tumors that we've thought about molecular subtypes for so long, is because we often encounter challenging cases. Some are extreme, like this, in which a patient on the left, walks into the office and without anything else about the patient that this is a cancerous malignant meningioma. But yet, sometimes patients are fulminant in over many, many years, such as the patient on the right, which up to her 6th surgery with our group, her tumor was still labeled a grade 1 meningioma. So clearly there is a discrepancy between the actual behavior of the meningioma and its labeling, or what we often say, the wolf in the sheep's clothes versus the sheep in the skin. And this has been attempted for almost a century by many, starting from Harvey-Cushing to the World Health Organization, to have better guidelines for how we can use a label found in the tissue of the meningioma to predict its long-term behavior. The most classic, the most commonly used grading system is that of the World Health Organization grading system, which in 2021 took a step towards the incorporation of molecular features by incorporating the homozygous loss of CDKN2AB and TERT promoter mutation as formal criteria for that of grade 3 meningiomas. And these were based on a handful of studies that consistently demonstrated that loss of CDKN2AB, like in many other cancers, was associated with worse survival, as seen in the gold curves compared to the black, as well as that of TERT promoter mutation associated with worse survival in meningioma. The singular markers helped lend insight into more aggressive meningiomas. However, they are rare. They probably represent 1% or less of epidemiologically of the tumors that we encounter. And so then a wave of studies came out which were able to show that genome-wide analysis, whether by methylation or by gene expression or many other types of platforms, better predicted recurrence. These are 2 plots from beautiful studies from the Heidelberg and German consortium, where Breyer curves, where the lower the curve, the more reflective of reality, or the lower the prediction error. And here you can see the methylation classes, and there are at least 4 different ways to define methylation groups across the literature, seem to be better than the World Health Organization shown in red in long-term prediction of outcome. And so the acceptance of this was rapid. The only problem, at least for us here in Boston, is that we don't have a methylation platform or even a gene expression platform. And so then the issue, as the world caught up to this, is how do we think about better predicting outcomes of meningioma in a way that can be scalable and transparent so that we can make it more accessible to a broad audience? In other words, how do we translate discovery to implementation? For us at our hospital, which is formerly named Brigham and Women's Hospital, the women's part of that name means that 5,000 babies are born here. And those babies undergo karyotyping for things like trisomy, Down syndrome, and so on. And so we have the opportunity to do genome-wide chromosomal alteration screening for every meningioma resected here over the last 15 years or so. That led to experience of about 1,300 meningiomas that we had these chromosomal profiles for. And what that really means, if you look at this picture on the left, is that for grade 1, every single vertical tick mark is an individual tumor. And each row is a chromosomal alteration from chromosome 1 through 22 going down the y-axis. Grade 1s are on the left and grade 3s are on the right. The presence or absence of a blue or red, or what we call messed upness, is that of a copy number loss versus a chromosomal copy number gain. The bland neutral cream color is a normal karyotype or in the genomic of this meningioma. What we quickly observed is that there were a whole bunch of blues and reds throughout these tumors, especially in the high-grade tumors, but there was also about 20% or so of the grade 1 meningiomas that looked just as messed up as the high-grade tumors, and vice versa, a percentage of the atypical meningiomas that looked just as bland as the grade 1 meningiomas. And it's been known for a long time that chromosomal copy number alterations are a signature of more aggressive high-grade meningiomas, whereas grade 1 meningiomas often have mutations, that they may be separate biological processes that lead to the inception of these tumors in the beginning. And so we took a simple method of looking at every possible feature that we have access to, every chromosomal alteration, every molecular feature, histopathologic feature, even gender, age, so on and so on, and looked at every feature that potentially associated with occurrence in a very clean cohort of newly diagnosed, never previously radiated tumors that seem to undergo complete resection based on radiographic evaluation, and a whole barrage of features emerged. CDKN2AB loss had the highest hazard ratio, about 70-fold risk of associating with recurrence, but everything else underneath, there are many of these dozens of other features also associated with risk. That led us to develop what we call a molecularly integrated grade using a combination of many of these features. And I'm sorry that my slide on that somehow disappeared from this. A molecularly integrated grade in which the only difference between what we did in calling this versus what we have in the past is that in the past, we and others tried to be parsimonious and pick a couple of very commonly observed aggressive molecular features that were associated with behavior. And that sometimes worked and sometimes didn't. But we recognize that meningiomas, just like humans, have many different shades of skin color and many different unique signatures. And rather than by using an and, as for example, that a meningioma has a chromosome 1p loss, a 10 loss, a 14 loss, or so on, we switch the and to an or, saying that any combination of these, barrage of high risk features that are associated with recurrence can potentially contribute to that of a more aggressive behavior. And we created 3 integrated grades, molecular integrated grades, that in essence removed histology and looked at any combination of these high risk features. And for us, the reason why we quickly adopted this in our institution is because of this single figure in which tumors that are discrepant, in other words, that are so-called malignant, WHO grade 2 to 3, but molecularly bland, integrated grade 1 in the blue line, did a whole lot better than tumors that were molecularly aggressive, integrated grade 2 and 3, but histologically bland, WHO grade 1. And so this discrepant figure really allowed for us to distinguish behavior. Furthermore, brain invasion, which is a criteria for at least grade 2 or more in terms of the WHO grade, when we separated those tumors with brain invasion by their molecularly integrated grade in the blue line, they seem to do a lot better than the same tumors with brain invasion that were molecularly aggressive in the red line. And so it was reassuring to us, since the topic of this is longitudinal follow-up, that the more time that passed, you can see on the x-axis, this is time, over a decade of follow-up, the more time that passes, the better molecular classification gets in determining outcome. And that makes a lot of sense because meningiomas, even more aggressive ones, often need quite a bit of time to declare itself. In fact, in the first 3-ish years of follow-up, there was no real difference between molecular features and the WHO histopathologic features. It's only as more and more years came that the curves started to spread more. It also speaks to the importance of long-term follow-up and doing studies for meningiomas to really discern the impact of any sort of observation that we have. One of our initial motivations for thinking about molecular criteria is that of scalability to the world at large. And so no matter, even though something like chromosomal copy number alterations is easily derivable from almost any possible genomic platform, one can derive the loss or gain of a broad chromosome through methylation, through gene expression, through mutational signaling, through microarrays, through any of these platforms. But even that is probably not fully accessible to some swath of the population. But however, if one has the capability to determine an oligodendroglioma, which has 1p19q loss, one has the ability to determine a potentially more aggressive meningioma, as shown in this plot, where the more features that are included in a prediction scheme, including first and foremost just chromosome 1p loss alone, the better the performance gets over time compared to histopathologically driven WHO grade. And so this ability of scalability allows for the individual institution, hopefully, to be able to tailor that to their resources. The one issue that came up, as I mentioned, that the theme of this is about scalability, is that then colleagues begin to ask, well, how much of a chromosome do you actually need to lose to be a chromosome loss? Well, we use 50%, UCSF uses 80%, Heidelberg uses 5%. Can these all mean the same thing? We took to look at that in a systematic way because I really don't know. And so we took 2 random thresholds, ours, which is that 50% of a chromosome needs to be lost or gained to be called a chromosome alteration, versus a 5% alteration. And without looking at this too closely, you can immediately appreciate that the length of the bars, either blue or red, differs on the 2 columns. And in other words, the frequency that something is called a chromosome loss or gain differs depending on the threshold. And in fact, when we plot this out for each chromosomes, as shown in each of these lines, from a 0% threshold to a 100% threshold, you can see that thankfully most of the cutoff points are fairly stable. They're a plateau, and that most of that cutoff associates with recurrence, but the 2 ends are more unstable, and that some of these chromosomes have a more linear relationship with potential the association with risk. And so what that means is that for something like ours, a molecularly integrated grade, depending on where we set our threshold, it's going to influence potentially the prediction of outcome, either as being more lower grade, a higher prediction of lower grade tumors, or a higher call of higher grade tumors. And that also percolates to several other molecular classifiers out there, which includes chromosome copy number alterations, and that this is most impacts the intermediate, the gray zone tumors that are integrated grade 2, whereas benign tumors are benign no matter how you look at it, and aggressive tumors are aggressive no matter how you look at it. So it's really that intermediate zone tumors that the thinking of choosing an optimal threshold should be refined. But reassuringly, whatever the local institution is already using is probably good enough at the moment, because most of these lines, again, from 0% to 100%, are tightly clustered, except for when you get to near whole arm alterations. 97% or greater really falls apart in the prediction schemes. And that applies for both the whole genome-wide analysis, but even for singular markers like chromosome 1p loss. This consideration of thresholds, I highlight because as we use more and more of these, we're going to start to find differences across institutions. And rather than saying, I think, who's right and who's wrong, thinking about how we implement these criteria, I think is a fundamental first step that the field needs to come to agreement on. And furthermore, for us, for example, both heterozygous and homozygous loss of CDKN2A has a similar negative prognostic feature in meningiomas. And so that almost any sort of, because the criteria for heterozygous and homozygous loss can vary and can be a little bit tricky sometimes depending on the platform. But knowing that any degree of loss in this locus is a bad thing for meningiomas, I think liberalizes us to think about it further. The other feature that I mentioned is associated with negative behavior in meningiomas in the WHO grade is that of TERT promoter mutation. It happens that for us, retrospectively in our cohort, we had 3 TERT promoter meningiomas that did not have any high-risk copy number alterations. In other words, they would be an integrated grade 1 for us. And these tumors did not recur. That seemed to set off an alarm because the difference between a malignant meningioma, where someone is preparing for, cancer and death, versus a tumor that doesn't occur after almost a decade of follow-up, is quite different in the psychology and the counseling and management, much less the receipt of adjuvant radiation. Given how rare these mutations are, we pulled together the generous contributions of 15 partner institutions to pull together over 1,500 meningiomas that had TERT promoter sequencing, and really observed that amongst TERT promoter mutations, there are still differences in the histologically bland, seen in blue, versus the histologically aggressive meningiomas. And that if we do not upgrade meningiomas solely based on the presence of a TERT promoter mutation, that these tumors, have quite different outcomes. And we observe that TERT promoter mutation is commonly co-occurs with that of other aggressive features, and that these other aggressive features include aggressive markers such as CDKN2A-B. And so that when we control for these other features that are associated with aggressive behavior, we actually find out that TERT promoter mutation on its own may not be so devastating for meningiomas. And so this highlights an example of really seeing each feature as we include molecular features more and more in daily life for what they are, and being able to take into account confounding factors and co-occurring features so that we're not overcalling that molecular features, just like anything else, should be context dependent. And that context can also include the context of surgery and the other treatments received. So in conclusion, I think that we are in a very exciting age of evolving understanding for the molecular understanding of meningiomas, and that perhaps some of the features which are recently incorporated even in international standards may still be subject for further scrutiny in the future. So thanks so much.
That is awesome work. Thank you, Dr. B. Really exciting work. I guess we'll save questions for the end, and we'll go now back to Dr. Alex Miller, who's all set here. Thank you, Dr. Miller.
My Zoom has come to life, so apologies for that. So thanks so much for that invitation to talk today. I'm going to give the neuro-onc perspective on this and talk about molecularly targeted therapeutics in gliomas. These are my disclosures. I don't think they're relevant for today. So, in summary, I would say a lot happened in 2021. As everyone here knows, the WHO classification made some really essential and important, and I think very necessary changes in terms of the grading of gliomas. So there are no more IDH mutant glioblastomas. We've now, begun to incorporate molecular features into the designation and the classification of all of our gliomas, and in particular, our low-grade gliomas. There are more molecularly defined entities. These include diffuse astros that are IDH wild type with molecular features of glioblastomas. For the first time, we can now call a tumor a glioblastoma without having histological features of it under the microscope. We've also now defined diffuse low-grade gliomas that are MAP kinase pathway altered, and now define diffuse midline gliomas by the presence of the H3K27M mutant tumors. And as Linda obviously just talked about, also made many changes to the meningioma grading system. So, you know, as we've gone through today, accurate molecular diagnosis is now completely essential for glioma classification. So just to walk you through this, now when we see a diffuse infiltrating glioma on an MRI scan, our first question is whether there's the presence of an IDH mutation. And this is absolutely critical for patient prognosis and downstream treatment. So if a patient does have an IDH mutation, the next thing that we look at is, whether this is an astrocytoma or an oligodendroglioma, and that's based on the presence of a 1p19q co-deletion, which of course defines oligos now, and the presence of an ATRX and p53 mutation are often co-occurring with our astrocytic populations. And, of course, equally important is the absence of an IDH mutation, which now defines our IDH wild type population or our glioblastomas. This diagnosis can now be made with the presence of a TERT promoter mutation, an EGFR amplification, a chromosome 7 gain, as well as the histologic features of necrosis or microvascular proliferation. But these are no longer necessary to make this diagnosis, and now these molecular features are just as critical as the pathologic features, and these patients can fortunately now be included on clinical trials. So I think, this is the dawn of a new era, but the question still comes to light in clinic really every day, whether molecular profiling in gliomas matter. So I'm going to start by talking about two situations where it clearly does and has changed everything that we do. So two landmark papers came out in 2023 in the New England Journal of Medicine, the vorasidenib and IDH1 or IDH2 mutant low-grade gliomas, and in Nature Medicine, the type 2 RAF inhibitor tovorafenib in relapsed or refractory pediatric low-grade glioma. This is the results of the phase 2 Firefly trial. And this has really changed what we do and how we behave in terms of our treatment decisions for these two patient populations. So first, I'm just going to go through a little bit more about the Indigo trial. So the Indigo trial, as everyone has talked about already today, but enrolled patients with IDH mutant gliomas, WHO grade 2 tumors or patients. These patients had had surgery, but they had residual or recurrent disease. But it's very important to understand that these were patients who the neuro-oncologist felt did not need chemo or radiation. So these were low-grade patients with really small amounts of disease who were generally asymptomatic or with very minor neurologic deficits. These patients were randomized 1-to-1 to the IDH inhibitor vorasidenib versus placebo, and then the primary endpoint was imaging-based PFS. So I think shockingly to many of us in the field, the results of this trial came to fruition very, very quickly, and treatment with vorasidenib nearly tripled progression-free survival and increased the time to next intervention. And so the trial was terminated, based on this clear separation in the Kaplan-Meier curve in terms of progression-free survival. And this is really a promising strategy to increase survival and delay potential neurocognitive effects of chemo and radiation in a young population. But, there are many important conclusions that came out of this trial, but many questions that still remain that we're grappling with every day, in the clinic. So I think this trial offered really exciting and convincing results that there is a crucial role of 2HG in promoting the growth of low-grade and non-enhancing untreated grade 2 IDH mutant tumors. This trial confirmed the importance of 2HG in the growth of recently diagnosed, previously untreated IDH mutant tumors that are not contrast enhancing. And the really compelling results from this trial really bring into question whether there are any patients that we should watch and wait for. But there are many remaining questions. We don't know whether this actually impacts overall survival. In fact, we have no idea of that, and we're probably not going to know that for at least 10 to 15 more years. We also don't know if there's a role for any maintenance therapy combined with chemotherapy and after chemotherapy. And we don't know the efficacy for non-enhancing grade 3 tumors if, in fact, there really continues to be a distinction made between grade 2 and grade 3 tumors. It's the next WHO classification comes out. So how does this impact, what we do in clinic? I think, a patient walks in, and I think every neuro-oncologist now tries to put them on vorasidenib, and we really don't know who the right patients are for this drug. Even in the patients who stabilize, there's only a period of time that they stabilize. You're probably pushing the needle down in terms of when these patients will inevitably need radiation. And the question is, do you want to wait to radiate them? How are they going to do ultimately? Are you giving the tumor any chance to develop resistance mechanisms, or forcing it into a more aggressive state? So I think it's really exciting, and we're all really happy about these results, but we're gaining real world experience every day. There are also obviously important questions about fertility with these drugs, and considerations that you have to make with that in terms of putting patients on these medications for the long term. We don't know what happens if patients come off of them in order to have a pregnancy for a year. So a lot of things we're still learning. So next, I'm going to turn my attention to Firefly 1, which was the PNOC 026 trial that investigated the efficacy of the oral and selective CNS penetrant inhibitor tovorafenib in patients with BRAF-altered relapse or refractory low-grade glioma. So this had a registration arm and then an extension arm, and really very, very impressive overall response rate of 67%. This was true via Rano high-grade glioma, Rano rapno, and Rano low-grade glioma. And you can see here that patients were able to remain on drug and tolerate it well, with a median duration of response of 16.5 months and median time to response of 3 months. But similar questions, about these drugs in terms of keeping patients on them, when to use them, at what time point to pull the trigger and put patients on them. So, a lot happened in 2021, but a lot more happened in 2024. I think it was a very exciting year in the neuro-onc community. FDA granted accelerated approval to tovorafenib on April 23rd in 2024, and for vorasidenib on August 6, 2024. So finally, we have tools in our toolbox and things to consider besides radiation and chemotherapy. So, now that we know that molecular profiling can make a diagnosis, I'm talking to neurosurgeons here, but I think what comes into question is whether in fact you need tumor tissue. So I think, I'm obviously a proponent of surgery, and I think we still want to know the grade, the aggressiveness. There are many components, obviously, to which the tissue architecture can help guide us, but there are certainly considerations and situations where, in fact, obtaining tumor tissue may not be the best thing for the patient. So, we know that genomic tumor profiling relies on the collection of tumor tissue typically, which is obtained through a neurosurgical procedure. But this is particularly challenging in patients with brainstem, thalamic, spinal cord gliomas, or tumors that are in eloquent areas of the brain. So I think there's nowhere more relevant than for patients now with brainstem gliomas, which are really molecularly defined tumors by different drivers that mean extremely different things for our patient population. So obviously, getting a diagnosis of a diffuse midline glioma and finding an H3K27 alteration is an absolutely devastating diagnosis. It also guides clinical trial enrollment for, ONC201, ONC206, CAR T cells, and the many other trials that are developing in that space. Whereas we're learning more and more that many patients who have brainstem gliomas, especially in the adolescent young adult population, actually have IDH mutant brainstem gliomas, and these often have non-canonical alterations. So even in getting the tissue out of the OR, it's usually a much slower diagnosis because you have to wait for sequencing results rather than being able to rapidly make the diagnosis in 15 minutes in the OR, though hopefully we will solve that problem here in the not too distant future. So of course, the identification of an IDH mutation in brainstem glioma leads to the possibility that these patients could be treated with IDH inhibitors also. And then of course, there's a subclass of brainstem alterations with BRAF mutations, PDGFR alpha mutations, and other things as well. So I'm going to just show you some results of our CSF sequencing results. We hypothesized that minimally invasive liquid biopsy of CSF could represent a superior diagnostic modality for patients with brainstem gliomas, employing molecular diagnosis and analysis of cell-free DNA. So in a cohort of 37 patients with intrinsic brainstem lesions that were seen on imaging, we used a multi-step process in order to identify driver mutations in the CSF. So what we did was we had an N of 46 CSF samples across 39 unique patients, and we sequenced them. This work was done while I was at MSK, according to our MSK Impact platform, which is a next-gen sequencing panel of 505 of the genes that are most commonly altered in human cancers. And we have a clinical pipeline. So we ran that clinical pipeline on these mutations, and we found that driver mutations were identified via MSK Impact from CSF circulating tumor DNA in only 24% of cases. And we felt like this should be much higher, and we wanted to try and improve the specificity. So what we did was we went in specifically and we looked for these driver alterations. So we went in to see if there was any evidence of any mutant reads at our hotspot loci for brainstem gliomas, and we were able to identify a much higher percentage. And overall, using this multi-step process, we could identify driver alterations in 64% of CSF circulating tumor DNA samples from brainstem glioma patients. So this is particularly relevant for patients who cannot, or it's very risky to get a tissue sample for them. And we found in this group that CSF ctDNA was diagnostic in 48% of cases. I think we're still really working on the sensitivity of these CSF assays. There's a new company, Belay Diagnostics, who's running CSF, which is a spin out of Hopkins, which is incredibly exciting. They're doing a great job. We've had a lot of positive results already using that assay. And so in a situation where a neurosurgical procedure has a high risk of harm, and you guys are suspicious that these may be the drivers, I think it's really worth considering CSF at this point. We also have found that the presence of leptomeningeal spread of disease is highly associated with positive CSF circulating tumor DNA. These are the correlations of different various imaging findings and location of CSF collection with your rate of detection of CSF circulating tumor DNA. So this is just a case example. I have a patient, a young woman in her late 20s, who came to me during pregnancy with a newly diagnosed flare abnormality in her brainstem and some new onset diplopia. The neurosurgeons did not want to take her to the OR, considering the fact that she was pregnant and the high risk location of her tumor, and decision was made to do a lumbar puncture. She had CSF circulating tumor DNA extracted and sequenced, and we were able to confirm the presence of an IDH1 R132G alteration. This enabled us to hold off on treatment throughout her pregnancy. She delivered a healthy baby boy and then was treated with concurrent radiation, temozolomide followed by temozolomide. She's now gone on vorasidenib as a maintenance therapy. She's really doing great and is now off it trying to conceive a second child. So we'll see more to report in the future. But you can see this is her baby, Oliver, thriving. So in conclusion, CSF circulating tumor DNA sequencing has significant clinical utility in patients with intrinsic brainstem gliomas. Minimally invasive diagnosis in patients with intrinsic lesions has a high diagnostic yield and may obviate the need for tissue biopsy, but we really need more sensitive assays developed to maximize the rate of detection. So I just want to leave with this CARES report that I received yesterday on one of my IDH wild type GBM patients. This is a classic scenario. This happens to us all the time. A TERT promoter alteration, P53, P10, RB1, and here ARID1A. We still have nothing to do with this whatsoever for GBM patients, and we sequence all of them. And while I love to see it and in my mind draw my own conclusions as a result of it, this doesn't drive our clinical behavior whatsoever. So hopefully this talk next year we'll have more data and more information, but we're still working to solve the IDH wild type problem. So thanks to, this is my team at MSK who did the work on the brainstem gliomas, and hopefully more out of NYU next year. Thank you.
Awesome. Thank you so much, Dr. Miller. We're so thankful we have rapidly emerging drugs and diagnostics. Really good news, as you mentioned, in the last year or two. So keep it going. We'll save questions for the end. Let's go to our last lecturer, who will be Dr. Donato Passione. And Dr. Passione will be speaking to us about craniopharyngioma and BRAF mutations. Good to see you, Donato.
Hey, how are you? Thanks for having me. Let me see if I can share here with you. Hold on, it's actually going to make me log back in 1 second. Sorry about that.
Okay. Perfect. We can see that.
See my screen now?
Yeah, if you just would like to go to.
Yep.
Perfect.
Okay. So thanks for having me. Dr. Oringer had asked if I would present on some of our data that we've come together with about our modern management for papillary craniopharyngioma. And so I don't have any disclosures other than that I worked here with Dr. Wissoff, which does have some impact as far as my approach to craniopharyngioma, as he has been a big proponent of aggressive gross total resection surgically. And I'll get into sort of the pluses and minuses of that. So when we look at papillary craniopharyngioma, separate from your adamanthinomatous, these are relatively rare. They make up only a small population of all craniopharyngiomas, with really only about 600 cases per year. And what you find is that they have a higher rate of intraventricular and hypothalamic involvement. But most importantly, what's been discovered about them is this high prevalence of BRAF mutation, and that's seen in about 95% of papillary craniopharyngiomas. And so current treatment strategy for craniopharyngioma in general, it's radical resection and or subtotal resection with a combination of radiotherapy. There's even cyst drainage with Ommaya reservoirs and or shunt catheters, as well as radiotherapy, sometimes radiotherapy alone, and then more recently, targeted therapy. And that's kind of what we're going to concentrate most on today. But when we look at outcomes for craniopharyngioma, the reason why things like targeted therapy come into view and become important is that gross total resection, we know, has the highest rate of cure and lowest rate of recurrence, but also comes with collateral damage. And so we see that higher rates of panhypopituitarism when you have gross total resection. Looking at this is the RAPID consortium that we're a part of. Looking just at papillary craniopharyngiomas in this group, we see a similar outcome overall, which is that less rates of recurrence when you had higher rate of resection and gross total resection, but also higher rates of things like permanent AVP deficiency, as well as adrenal insufficiency. So there's always really a price to be paid by getting rid of these tumors in their entirety. When we look at other long-term outcomes, we see that it's not just things like panhypopituitarism, but you also have the hypothalamic involvement, which can increase things like obesity. And so this out of the Mayo group showed 98 patients where they had gross total resection in about half of them, but a significant increase in overall obesity after resection, and a 12% all-cause mortality, which they associated with, to some degree, with having the craniopharyngioma resected. So when we look at other quality of life factors, this was a study looking kind of broadly at quality of life markers. And what they found was that after resection from craniopharyngioma, central DI was associated with having a lower quality of life overall and might be a marker for depression. But in general, they were overall patients were not as healthy after craniopharyngioma resection on a variety of these different functions that they looked at. And then when we look, to the end of from a woman's perspective and what it means from fertility standpoint, this has a big impact on quality of life. And in this study, looking at women who had craniopharyngioma treatment and resection, 50% ended up going on to not have any further children. And everyone who did go on to have children required medical assisted reproduction. So it becomes a big part of the quality of life questions of what's going to happen after you have a resection, especially if you have a radical resection, which will likely, permanently impact your pituitary function and possibly your hypothalamic function. And then this is more from the pediatric literature, but looked, very in depth at trying to classify what are your risks of hypothalamic dysfunction from craniopharyngioma resection. And when you have these grade 2, which are the ones that involve the floor of the third ventricle and into the hypothalamus and even, up into the third ventricle, those have the highest rates of things like hyperphagia, morbid obesity, somnolence, behavioral and psychological disorders, and then thermal regulation issues. And with that group, the recommendation was made for subtotal resection that it's not worth the collateral damage trade-off that is going to come with fully removing that tumor. And so here's an example just of a 26-year-old with a very common looking, type of craniopharyngioma tumor, who initially presented with headaches, was not keen to undergo any treatment initially because was relatively asymptomatic, and was trying to decide about what she was thinking in terms of her fertility, because we talked about that ahead of time. So she observed it for about 4 years and it showed, continued growth. She had normal endocrine function pre-op and normal visual fields. But with the given growth and the impact that it was starting to have on her optic chiasm, she agreed to go forward with surgery. So we did this through an endoscopic endonasal approach with stalk preservation. We were able to get a gross total resection of the tumor and feeling that we were in good shape because the stalk was preserved. But even so, similar to what we've seen in some of the other studies and data, by about 6 months, she became pan-hypopituitary. And at 1 year post-op, she's got significant increase in her weight and has been dealing with obesity ever since, but has not had obviously any evidence of any recurrence. And so we do have a gross total resection, but with collateral damage. And so our other options for treatment for these tumors would be radiation in some form, whether it be as a primary treatment or in addition to resection. And what we see is that the outcomes from radiation seem to be very good and similar to what you see with gross total resection as far as control rates. So here we have a similar 5-year control rate between gross total resection and subtotal resection. And really the only issue is of failure happens to be because of underdosing, often due to sparing the optic apparatus. And then proton therapy, which has also been a treatment option for craniopharyngioma, similarly comes with toxicity that can become impactful for people in terms of quality of life, whether it be from vision disturbances, further endocrinopathy, or even cognitive and memory disorders as a result of late toxicity of the radiation treatment. So when we look at radiation effect, we look at a case like this. This is an adenomatous craniopharyngioma treated at an outside hospital, who presented with worsening of his vision. Baseline had panhypopituitarism from his previous surgery. So he's undergone multiple resections, cyst catheters, and then underwent radiation therapy with 54 gray of XRT. 2 years post-radiation, he began to develop basal ganglia strokes, and then he developed multiple areas of vascular narrowing, similar to a moya-moya type picture. And unfortunately, 3 years post-op from his radiation, died of a severe stroke. So, radiation itself can have some pretty significant long-term side effects for patients. And so when we talk about craniopharyngioma, it's really treatment versus damage. And, how much are we going to hurt in terms of collateral damage along the way? And is there a better way to deal with it? So this is where targeted therapy, I think, comes in. And, this is the new frontier to some degree, and I think is going to be helpful in trying to avoid damaging everything else in the process. And so when we look at the group out of MGH, who put forward this New England Journal article a couple of years ago, looking at BRAF and MEK inhibitor inhibition in papillary craniopharyngiomas. So we know that 95% of papillary craniopharyngiomas have the BRAF mutation. And so they went about trying to treat this as their target with BRAF and MEK inhibitors. And they found an excellent response rate of 94% and tumor volume reduction by 91%. 7 patients discontinued the treatment after full regression and had no further treatment with complete control of their tumor. Unfortunately, the study only has about 23 months of median progression-free survival off of treatment, and still needs obviously further work to see how it would hold up long-term. But this is obviously extremely promising because these patients don't get exposed to the same type of collateral damage that comes with resecting a craniopharyngioma in totality. And so trade-off here, there are adverse effects of the medications, and that's oftentimes why patients had to stop the medication or stop their treatment. And you can see the list here can be something mild, like just an allergic reaction, but can also be very severe in terms of hemorrhage and so on. So this is part of the discussion that has to happen with the patient as far as, is this worth it versus what you might get from surgery? And so here's an example of a patient who presented with this hypothalamic mass, which was observed initially and then grew over a period of 9 months. At baseline, she had normal endocrine function and normal visual fields. And so we discussed, should she have a biopsy, a subtotal resection, or a gross total resection? Given what we know about this potentially being a papillary craniopharyngioma, I had recommended she try a biopsy first and see if this was in fact a papillary and if we could consider targeted therapy. So she agreed to going forward with an endoscopic biopsy. So I did an endoscopic transventricular biopsy. Histopathologically, it was initially read as a BRAF negative. However, with methylation and genomic analysis, it was actually determined to be BRAF positive. So we didn't actually get the diagnosis till about 2 weeks after her surgery. Once it was determined that it was BRAF positive, we then put her in for MEK inhibitor therapy. But she unfortunately had some very severe side effects and reactions to the medication. So she tolerated it for a few months. After her first couple of months of treatment, she reduced down to what you see here. So really a nice response and reduction overall. And then because of her inability to tolerate the medication, we then treated her with gamma knife radiosurgery to the residual in an attempt to control it that way, thereby reducing the actual radiation side effects that she might have to experience. So she got 12 gray to the residual. She continues to have normal pituitary function and normal visual fields. And so, we're still waiting to see how she is about a year out from this and how well it'll be controlled once she's off medication and with the treatment with gamma knife radiosurgery. There's another case of a patient with non-small cell lung cancer who actually had gamma knife 3 years earlier for a third ventricular lesion that was presumed to be a metastasis. However, she then presented with worsening bitemporal hemianopsia, had normal endocrine function, but had this on her scan, which had increased in size from the initial, what was thought to be a metastatic lesion 3 years earlier. We can see this is our growth pattern. And so as a result, she underwent surgical resection with the assumption that this was going to be a metastatic tumor. We had done a transventricular resection with the idea of just decompressing the optic apparatus and trying to avoid making her panhypopituitary. So post-op, she had an improvement in her vision. She had normal endocrine function, but her pathology came back as a papillary craniopharyngioma. So she was then started on MEK inhibitor therapy at 2 months post-op. And we see her reduction now, and her tumor is down to this size, and she's tolerated the treatment very well with continued normal endocrine function. So in both of these all three of these situations that we talked about, there's a delay between the diagnostic time and when the treatment is started. And really that's because we had the luxury of doing it. But what if you can't wait? What if the patient needs to either have a decompression right away or start therapy right away? And how do we go about trying to determine, do we have a targeting option? Is this a papillary craniopharyngioma? More in real time as opposed to having to wait for this. So this is a 29-year-old woman who came in with blurry vision and worsening headaches. She had normal endocrine function and a mild left inferior quadrant defect. So because of the vision issues, the idea was that this either needs to come out or we need to find out if it's a papillary tumor right away so that we can begin treatment. And so we talked about the options of a biopsy, a subtotal resection, or a complete resection. And what I told her was that we wanted to get an answer of what it is as quick as possible, and then we could go and move on to further resection if it came back that it was not a papillary craniopharyngioma. And so this is where Dr. Oringer's lab came into place. He kind of spoke on this a little bit already and mentioned some of his work here. But ultra rapid droplet digital PCR was sort of the key to being able to make an intraoperative diagnosis in real time. And so what they did was reduce the PCR result to approximately 15 minutes to allow for real-time diagnosis of a papillary craniopharyngioma with a BRAF mutation in the OR. And so this is more data from his lab showing essentially how they tried to extract DNA and reduce their time from 30 minutes to 5 minutes, and that it showed a similar response as you would to your standard DNA extraction. And then ultra rapid thermal cycling, reducing your time from 2 hours to approximately 3 minutes. And so you got this under 5 minutes was the initial goal. And this is the lab setup that's in a room essentially right next to where the OR is, so that this can be processed quickly. And so having this technology available, I told this patient that we were going to try to make a diagnosis right then and there. If it looked like it was not a papillary craniopharyngioma, we would move to complete resection, which would make her panhypopituitary given the position of the tumor. And she agreed to that plan. And this is just kind of a quick video just showing the size of the opening that we would make to get a kind of minimally invasive biopsy, essentially, through an endonasal approach. So really just taking down a small portion of the tuberculum to avoid anything major in terms of CSF leak. And as we open these leaflets, you're seeing in front of us is actually the pituitary stalk that's splayed out over the front of the tumor. So then we go looking for sort of a nice pathway or window to work in that's less likely to disrupt the stalk. So as we move to the side of the mass, we start to see an area that's a little less consistent with the stalk, and we're able to separate portions of the stalk off the surface. And then once we get to an area that looks like it's safe for biopsy, then we take a couple of small samples of this, and really doesn't need to be a very large piece of tissue, just a small little portion, which you'll see a little bit more here. But here's it separating away, and you can really start to see the normal stalk versus the tumor there. But this is us grabbing small pieces, and those are sent off right then and there at the time in the OR. And within 15 minutes, we had our result, which came back positive for BRAF mutation. So we knew we were dealing with a papillary craniopharyngioma. Our pathology was not confirmed for 48 hours post-op, so we had a little bit of a lead time on standard pathology. The patient was then discharged home on post-op day 3. She had normal endocrine function afterwards and continues to have normal endocrine function. She was started on dual inhibitors with an improvement in her headaches as well as her vision almost immediately. And this is her 3 months after starting the BRAF and MEK inhibitor therapy. You can see a significant reduction in the size of the mass. It's really only left down to a small area of enhancement along the infundibulum, but you can also appreciate how any resection of this tumor would have likely permanently sacrificed her pituitary function. And just as an example of a control case, so this was a patient with an adamantinomatous craniopharyngioma who had come in around a similar time when we had this technology available to us, and we were taking her to the OR for resection of this growing cyst. And similar to what we did in the papillary case, we sent off our samples, and 4 out of 4 were negative, confirming that this was clearly not a papillary craniopharyngioma. We went on to proceed with a complete resection of everything there with stalk preservation. The patient had no DI after surgery, but had already been relatively hypopip beforehand other than DI. She did have an improvement in her visual fields, though, from the decompression. But this was a nice sort of example for us that not only were we properly identifying the BRAF mutants, but also in your normal adamantinomatous craniopharyngioma. And so, looking to the future, as Dr. Miller sort of alluded to, I think, really the ideal for papillary craniopharyngioma would be a liquid biopsy starting either with CSF, or the holy grail would just be with a blood test. And could we get cell-free DNA to confirm a positive test just from, taking blood? And that would avoid the need for any type of invasive biopsy. Even though we are trying to be as minimally invasive as we can, there still are risks. And then the other questions are treatment length and the SRS pathway. So we've seen that some people tolerate the medication well, but people can't necessarily tolerate it indefinitely. And so one of the questions really is, how long do people need to be on it for? And is there a period of time that would be more ideal in terms of discontinuing? And or should we be considering SRS treatment and gamma knife, to any residual that's there as an adjunct to treatment in order to help people to transition off of treatment, as we did in one patient. So, those are, I think, two questions that we're going to be looking into more long-term as we see what some of these effects are. And then the last is radiomics. And, this is another area that a lot of people are looking into to see, can radiomics accurately, determine if this is a papillary craniopharyngioma instead of an adamantinomatous. And I do think that there's going to be a lot of progress made in that area. I still wonder if neuro-oncology would ever be comfortable with treating someone with things as toxic as these dual treatment MEK and BRAF inhibitors without a true biopsy and only a radiomic a diagnosis, essentially. So I do think that in the end, some form of biopsy, whether it be liquid biopsy or actual tissue biopsy, would be necessary in order to make that jump to say, okay, we're going to go ahead and start to treat this patient with a MEK and BRAF inhibitor. And so I just want to thank everybody on our team, and obviously people in Dr. Oringer's lab, who have done all the work to sort of make this possible for us to be able to get real-time diagnosis in the OR for BRAF inhibited craniopharyngiomas. All right.
Awesome. That was a fantastic talk. Really enjoyed it. Thank you. It's amazing that we're getting the diagnostics down with, I love that droplet PCR technique. So that's really encouraging. And I agree with you. I think we're going to need tissue confirmation, Donato, of a lot of these markers you can't often tell the various subtypes, the adamantinomatous and papillary with imaging, but it's probably not going to be good enough for a while to give those very toxic drugs or whatnot. Do we have any questions from anyone? I think we have a couple minutes till half hour is up here.
Well, let me ask a question here. So really nice talks, everybody. I mean, I think they're just high quality, timely, innovative talks. And I guess my question is more directed towards Alex. We as neurosurgeons are in this situation now where we're going to the OR and we now have to make decisions about how much of the tumor we're going to take out based on some of the real-time data that we're getting. And, we have kind of moved along the paradigm of, taking out as much of the tumor as safely as possible. Do you see us kind of, stopping short because there's some medical drugs, and I mean, this applies to all the speakers, where we say, hey, we're not going to be as aggressive in this case because we know this is an oligo that's going to respond to other treatments. And, we don't need to push the envelope. And it kind of goes against what we've been taught as neurosurgical oncologists, right? Because we always want to take out as much of the tumor as we can and preserve neurologic function. So maybe, Dr. Miller, you could start out answering that question. And if anyone else has some thoughts, please chime in.
Thank you. I think it's a great question and a great point. I think there are limited scenarios where our treatments are actually effective and should be considered and taken into account, like the story that Donato just told, for example, or potentially the story, with biopsying for brainstem or spinal cord gliomas, where really, either our diagnostics or our treatments may obviate the need for surgical intervention. In terms of gliomas, while I think we're all very excited about VORA and IDH inhibitors, period, that trial was stopped early and, everyone was very excited about the results, as am I, but we're still talking about, 27.7 months until progression in, patients who are usually in their, 20s or 30s. That's nowhere close to getting, to the type of survival that we're hoping for that patient population. Will we one day maybe be there? Maybe, but I don't think we want to count on VORA to do the job of surgery at this moment, nor do we want to count on PCV, though I know the oligo data is hazier. So I think right now, we should resect as much as we can safely resect without doing significant harm to the patients, and then medically manage as best that we can and continue to strive for strategies that will combine both modalities.
Shawn, what do you think about that?
He's on mute.
He's muted.
May have had to hop off for a little bit.
Well, while he's unmuting, I don't think my comment was invited, but I'll provide it anyway.
No, Dan, please, anybody. I think it's the point we all think about, right?
So I mean, certainly, where it's feasible, we want to achieve gross total resection. I think the cases that are interesting are the ones where we have to decide about how close we come to working around eloquent areas, working in a way that may induce a deficit. And I think for astros, it makes sense to push the limits based on those curves. For oligo, it's a lot harder to justify because that very long-term data, independent of the increasing armamentarium of molecular technologies, that long-term data with oligos, there's no statistical significance between the curves in the paper that Dr. Hervey-Jumper and his colleagues published in JCO. So I think we have to take that information into account. And if we are using the same approach for every patient, then we're sort of closing our eyes to the differences that exist in the long-term survival data in astros versus oligos.
Linda, any analogy to meningiomas?
Yes. If you're going to say that I am not a religious person, but I think God helps those who help themselves. And for us to be able to walk away from a moment in surgery, which is safe and where you could do more resection, because that's the question, of not necessarily walking away from unsafe surgery, but if you could do safe resection within the normal parameters that previously existed, then that just doesn't make sense to me. Because I think that a lot of these results are really predicated on very long-term follow-up. And I'm not sure that we have that very long-term follow-up yet. In the sense of targeted or precision medicine or targeted inhibitors, one of the more targeted it is and the more precise it is, my fear is always that cancer is so smart, it has a room for evolution and for acquired resistance. So it's a matter of time. And so I do think that every party should do their part, to be able to be as safe as possible.
Good.
So I think what Linda brings up is obviously some of the difficulty when we think about craniopharyngioma, which is, do we walk away from a situation where we can probably safely take the tumor out, in that most of the time, all the cases that I showed, you could do a gross total resection on those and the patient do pretty well overall in terms of a safety standpoint, but it's the long-term price that's going to be paid from a quality of life standpoint. And that's where I think, if you have a target, even though it is a bit of a leap of faith, which it is to some degree, that you have to say, okay, I'm just going to biopsy this. And if it is something we can treat with targeted therapy, hoping that the targeted therapy works. But seeing some of these drastic reductions in tumor with that and people maintaining their, quality of life as far as endocrine function, hypothalamic function, I feel like that has to be something that drives our decision-making. And that's where, the Dr. Oringer's, lab coming in really made a huge difference there, of being able to say that right then and there, that, hey, we got a target, let's back off. And this is smart. This is safe.
That's definitely the future. No doubt about that. I have a really quick question if we have a second. Actually, Linda, I would love your take on this. It pertains, I guess, mostly to meningiomas, but the role of radiation is really big, especially in meningiomas, I feel like, with, chromosomal instability and even TERT mutations. And how do you separate that so many of these patients we see are post-radiation for their grade 2, grade 3, or even grade 1 meningioma? Do you have any takes on that?
Yes, so when we devised our kind of at least molecular classification system, we took away radiation to look at just the pure genetics. We took away the contribution of radiation. So none of the classifiers, I think for Heidelberg, the same as well, were developed on pre-radiated tumors. So that's one. I think the question of how to think about radiation in the face of increasing molecular information is also, you know, very nuanced and rather complex, depending on the bias of the individual provider. I tend to think that the risk of recurrence, or the reason why a tumor recurs, you know, either with or without prior radiation, probably is a combination of the biology of the tumor or a failure or representation of inadequate prior treatment, however one sees that. And so I do think that doing our best, you know, for whatever modalities that is, can impact the long-term outcome. Furthermore, I think a lot of people assume or ask if we are able to better recognize a more aggressive tumor, not like the truly malignant, but that intermediate atypical grade, that it's probably more likely that we recommend adjuvant radiation up front, because I do truly think it's going to come back in 5 to 10 years. However, it's actually the opposite, because when I think all possible literature that at least in my reading, when something's really biologically aggressive, there is a durability of control with all existing treatments, whether it's surgery, radiation, or both. And so then it comes down to the age of the patient. You know, I think our goal in tumor surgery or tumor care is to try to get the patient to their natural lifespan with a maximum quality of life. And so if it's a 35-year-old who I think the tumor might come back in 10 years, but I use radiation that moment, I use radiation in 10 years when it comes back, I probably will be out of options by the time they're 55 or 50. And so in those cases, knowing, and if the patient is educated enough and compliant enough, and knowing that they will come back, I tell them that we're going to watch it and potentially consider it a salvage option for the sole sake, not of preventing recurrence as the endpoint, but of buying them more time at the tail end of that curve.
All right. Well, I want to thank all the speakers today. This was a really, really nice webinar, really informative. I learned a lot from this, and I'm sure everyone else did. All of our webinars are recorded. They're on the tumor section website. So if you couldn't make it today, you'll have the opportunity and pleasure of reviewing this later. Thank you, everyone, and really thankful for all we did today.
Thanks, everyone.
Thanks.
Thank
Have
you.
a good day.
Bye.